MHC-TV is here to explain and demystify a variety of health issues and treatments with leading doctors in their fields who practice right here and are available to you. And because we all know the importance of diet and exercise to good health, we are featuring segments on easy and fun solutions to get you and your loved ones moving. You'll also be coming over to my house, where we'll be cooking some of my favorite recipes to show you how simple, tasty, and satisfying healthy cooking can be. Our shows are about education, so you can make healthy choices for a healthy lifestyle. So come on in and let's get started. Welcome to the Medical Health Center here in Middletown, New Jersey, where we've been keeping the community connected to primary, preventative, and expert specialty care for over 15 years. Medical Health Center is a state-of-the-art facility that can test, treat, and address multitude of health issues right on site. Aside from this hub facility in Middletown, we also have sister centers located in Tinton Falls, Red Bank, and Hazlet. And now that Medical Health Center is a division of Barnabas Health Group, we also are connected to Monmouth Medical Center, Newark Beth Israel, and other Barnabas Health systems throughout the state, which expands your access to expert care even further. In our particular center, we have multiple different tests that we can do. For instance, if you walk in and come to our walk-in and need a chest x-ray, that can be done immediately and you'll have your results immediately. We can do any blood work here and you'll have your results immediately. As far as cardiac testing, we take care of pacemakers and defibrillators here. We have echocardiograms, stress tests, nuclear stress tests. We have a bone density here. And all of that is done locally. Whatever we cannot do here, we have different diagnostic centers such as Shrewsbury Diagnostics, Monmouth Medical Center, and as well as the facilities throughout the state that will be able to do any diagnostic testing that you will require. Here in the office, your medical information remains local, but at the same time now throughout our network, whether it's with Newark Beth Israel or Monmouth Medical Center, your information easily is dispersed between our groups. And for instance, let's say that you have a problem on a Saturday or Sunday and come to one of our walk-ins, all the information from our group will be available to the physicians that's working that day. So we want to give not only easy access to you, but if you do come up with a problem such as a breast mass, we can refer you to our Willins Breast Center, one of the best breast centers in the state. And at the same time, the worry about where you need to go and who's going to take care of you will be dealt with us, your local doctor. And not only will you have your access here, you'll have access to our whole system, which is an extensive system throughout the state. At the same time, as medicine is going to develop throughout the next several years and decades, preventative care is going to be very important. Right now, we treat the patient after the medical issue has occurred. How about if we can not only start looking at you holistically, where we may identify certain medical issues that you have and start trying to develop a program for you where we can prevent future problems. So whether it's about simple health concerns or more serious ones, patient education is vital. And that's why we're bringing you this show. Hello, today we're here with Dr. Ajay Shah, one of our non-invasive cardiologists who trained at St. Luke's Roosevelt, Columbia. Dr. Shah has been with me for over 4 years and is a multiple board certified non-invasive cardiologist, such as echo, cardiac MRI, cardiac CAT scan, and peripheral vascular disease. Hello, Dr. Shah.
Hi there.
Before we start, I just, when we say non-invasive, most people, when they hear invasive, it sounds painful.
Right.
And I can tell you what Dr. Shah does is non-painful. So let's talk a little bit about echoes, for instance.
Echocardiography is a great modality. It's a modality. We use ultrasound that they use in the babies. We check out the heart with that. The technology has evolved into now three-dimensional imaging. And what I bring to the practice is the latest application with this modality, not only with the three-dimensional, but also the four-dimensional, and beyond that, more advances in that imaging.
Yes. Frequently our patients end up with valve problems such as aortic stenosis. Years ago, we'd have to do heart catheterizations frequently. Tell us, how has that advanced to the point where you can diagnose the severity of aortic stenosis?
Right. There have been many ways by which now echocardiography has taken over, but also patients who also have lung problems. Before, we used to put in the wires and do invasively assess their pressures. Now with the echocardiography, we can easily assess the lung pressure. It's very easy to do. Within about 10 minutes, the whole test is done, and whole complete evaluation of the heart with its valve, with all the blood flows, all the chambers, the contraction, and even looking at all the things like clots in the heart, they are all done. So,
some patients may have heard the term stress echo. I mean, we do stress tests here, right, and you're certified in nuclear, but tell us a little about what a stress echo is.
The stress test basically is involving to stress one's heart and see any problems the arteries or the muscles of the heart can have when they are at increased stress.
That's increased exertion, running on the treadmill.
Or the increased exertion. Echocardiogram has many advantages over doing with the nuclear agents. First of all, not only we avoid the radiations with that, but second of all, it gives us the information about the valves of the patient, about the pressure in the heart, and particularly in women, where we really want to avoid as much as possible the radiation, and certainly in their childbearing age group. I think stress echo is one of the modality of the stress test one should adopt.
Let's talk a little bit about cardiac CAT scans. We hear about cardiac CAT scans and the advances in that technology, and then what will we use a cardiac CAT scan for?
This is really making big leaps in patients who come to the emergency room with the chest pains. And it allows us to look and evaluate the arteries of the heart directly without having to stick any catheters inside the heart.
So you avoid what we call a heart catheterization.
So we avoid any invasive procedure. It not only allows us to look for the cause of a patient's chest pain in the heart, but also in the whole chest. So in fact, the studies have now shown that it cuts down the emergency room stay for the patients, and average stay, which used to be almost 24 to 48 hours, has cut down to now 6 to 10 hours. So patients can quickly a decision be made whether the patients have any high risk for chest pain or low risk for chest pain, and they can be sent home quickly. The hospitals love that, the emergency rooms love that. The emergency rooms, as we all know, gets packed up very quickly. Patients wait on the floor for the beds, and all the reason the stress tests, most of the hospitals are not even done on the weekends. So that means a patient coming on Friday then sits in the hospital till Monday. It's a huge hospital cost. It's a huge inconvenience for the patient and anxiety for the patients for the next 48 hours. Whereas with the CAT scan, within 6 hours, we can tell the patient that, and most of the studies have shown that almost 50 to 60% of the patients are able to go from the emergency room home within about 6 hours. So that's a big achievement.
But downfall, unfortunately, is it requires radiation.
It used to be a big challenge before, but of late, the radiation of the CAT scan has come down tremendously. In fact, now the radiation from the CAT scans is much less than the annual background radiation an individual would get, even not having any study. So it's even lesser than that. So that is the reason the American College of Cardiology and good number of the bodies are now adopting this almost as the first line of modality. In fact, most of the hospitals, including Mammoth Medical, is now trying to get that as a first line test in the emergency room.
So not only do you look at the coronary arteries, we look at the major vessels, and you also look at if they have some lung disease
Pneumonia maybe.
causing some of the
Yeah.
problems.
They can also have a clot in the lung. That could be causing, or at the same time, we look in the big arteries of the heart. You know, somebody they could have a problem in the chest with the arteries being dilated, or even having some ruptures, and we can see that.
So let's turn to a little bit about cardiac MRIs. I know you and I talk about congenital heart disease and cardiac MRIs, but why don't you tell us a little bit about it?
The cardiac MRI has many advantages. What cardiac MRI now adds to the armamentarium to assess the heart is very accurate quantitation.
When you say quantitation,
the quantitation
measurements, the accurate measurements,
accurate measurements of pumping of the heart, of the valves of the heart, and the timing of all the operations, and even putting in the pacemakers and defibrillators in patients is actually dependent on a certain number, whether how much is the heart pumping, whether the heart is pumping 35% below, that's when they put in a defibrillator in patient's heart to prevent sudden death. In the region, they have just started the adult congenital heart program, and that was all solely the basis that we strived hard over the last 3 years to build the only cardiac MRI program in this area. And now that it's well established, we could do that. We could offer this to this area.
Yeah, I know they have a large program up at Newark Beth Israel.
Absolutely. And without cardiac, an adult congenital heart disease program cannot run without a cardiac MRI.
And the good part about it is no radiation.
Absolutely no radiation, correct. It's very important that we as a cardiologist at every visit emphasize the patient about the importance of diet and exercise in their health, and that makes a big change to them.
Now that we've seen Dr. Ajay Shah show us some interesting cases on his valve problems on echoes and ischemic heart disease on stresses, we're going to talk to Dr. Saunders, who runs the cardiothoracic department at Newark Beth Israel Hospital. He's going to talk about not only bypass surgery, he will be talking about minimally invasive surgery and robotic surgery. Hello, we're here today with Dr. Craig Saunders, the cardiovascular chairman here at Newark Beth Israel. How you doing, Dr. Saunders?
Doing fine, thank you.
I know we've had several tough cases together over the last few months, but how long have you been the chairman here at Newark Beth?
I don't even want to think about that. 12, 13 years, yeah.
I know you have a robust program. Is this the only hospital you operate at?
Well, we have two surgical sites, Beth Israel and St. Barnabas, separated by about 15 miles.
And now I see with the advent of the stents and everything else that's coming down, I know that you get many more tough cases compared to what you've done years ago. But just for our public, you know, most of the patients we see end up with bypass surgery. That's narrowing of arteries with decreased blood flow. They get their chest pains and heart attacks. Now we do two types of surgeries here, right? Through the sternum and minimally invasive. Why don't you tell us a little bit about both?
Well, first of all, most of our cases now are valve cases rather than the bypass cases because of the stents and so forth. It used to be when I started out, 70%, 75% of the cases would be bypasses. Now it's almost 70% are valves and other types of surgery. But during that time also, there's been an evolution of how you do it, and the standard sternotomy incision, you know, what everybody calls a zipper club. And now, for instance, the mitral valve we can do through a small little incision right under the breast and just do it between the ribs. It can be done either with robotics or just with special instruments and cameras.
So when you're looking at, let's say, going through the breastbone, why would a patient require that versus the minimally invasive?
Well, that just depends on how much needs to be done, where you have to get to. You know, when you do a minimally invasive, you're kind of limited to focus on one area. And for instance, if you've got to do bypasses on one part of the heart and do a valve on another part, then you just need access to everything. But in special cases and people that have that fit the criteria, the small incision's a good idea.
And as we saw with Dr. Shaw over in Middletown, where he showed us some of his, you know, interesting echo cases and some of his stress cases, Besides bypass and valve surgery, what other surgeries do you do?
Well, we're one of the largest transplant centers in the United States now as far as heart transplants go. We do lung transplants and a lot of aortic surgery. In fact, we just brought in a new young surgeon, Mark Russo, from Columbia and University of Chicago, who is going to start an aortic center.
And is that where they're using many stents, or?
A lot of stents in the aortic, but up around the heart now, we're still doing a lot of that open. But it's evolving, yes, endovascular.
Now, it's evolved quite a bit. I remember, and I'm dating myself, but when I first started, the open heart patients would stay in the hospital 10 to 14 days on average. Now the length of stay is what, 3 to 5 days?
Well, we wish it was that small. And actually, when I started out with the minimally invasive, I was telling people, well, you're going to have a small incision, you're going to be fast. But the fact of the matter is, it's still open heart surgery. And you're still on the heart-lung machine in most instances, and there's still a little bit of irregular heartbeats. So we don't push that real strong anymore.
Now, many patients worry, where do we get the grafts for our bypass? And frequently we use veins and one artery called the lima. You want to describe how we harvest them?
Well, doing bypasses, you know, it's just what you say. It's a bypass. You get a detour around. And the best thing to use is an artery because it's used to the high pressure. There's 2 arteries that go down the chest wall here. And there's one on the left and one on the right. Very common to use one on the left. In younger people, where it's appropriate, we use both of them. We even use the radial artery out of the arm on some people because the arteries last better than the veins from the legs.
I always get so many frequent questions from patients post-bypass. Like, for instance, they want to know, when can we return to work? And when can we play golf? And when can we drive? Do you have any criteria to help them along with that? And the best one is for the, when can we have sex?
Yeah. Sometimes that's amazing when you see that. You know, that's a personal thing. When I was first out, I saw a guy, when I was a young surgeon, I operated on a guy and he was young and healthy, and I said, okay, it was 4 or 5 weeks after surgery, and said, you can go back to work now. And he looked at me kind of strange, and you know, he pushed around 500-pound bales of cotton for a living. So it's relative. I got a lot of people, though, that are in control of their own hours and do desk work and so forth. They're back to work very, very early. Driving, the nurses say 6 weeks, I say 3 or 4 weeks, you know. But we try and get people back to normal as fast as possible.
I'm even more conservative than that, especially with the golfers, because if you do go through the breastbone, I tell them, look, that has to heal like any other fracture. And I say, give it 2 months.
Yeah, work on the short game.
Work on the short game. Now, I know we're an advocate for cardiac rehab post-procedures, and particularly bypass. What's your feelings on cardiac rehab?
Well, I think that it's not mandatory in everybody, but it's good for everybody. There's a couple things. Number one, you go, you get the exercise, you get the workout, you get the monitoring and so forth. But another really important part of it is you're there with other people that have been through it, and you can change, you can discuss your stories with them, and you find out that what you're going through is what everybody else is going through. So I'm a strong advocate for the rehab. And
many of our patients probably haven't done any exercise for many years, and this is probably the first exercise they're doing.
That's true. Yeah.
Now, one problem I've always said, I still find it amazing that we still have patients that are smoking. And obviously that's a big risk factor. Are you finding problems with smokers still?
It's a lot less than it used to be, thankfully, but it's an addiction. And some people just can't kick it. And it's a serious problem, because not only does it accelerate the disease, but just in our short period in the hospital, you stop smoking, you begin to have the cough afterwards as the secretions are mobilized, more pain. It's hard to imagine why people are still doing it.
It really is. Well, do you see any new advances coming down over the next few years?
Well, the thing that we're going through right now is in valvular surgery is what's called the TAVR, or the transvenous or the transcatheter valve placement. And that seems to be working really well. And it's going to be a matter of finding out who the right patient is for that, who's going to benefit and who's going to benefit most from the regular surgery. But someday, there's absolutely no question, we're going to look and we're going to say, my God, we did that to these patients, you know? It's getting better and better.
Yeah. And with a population that's growing and patients that are at higher risk for major surgery, obviously that's a new avenue.
Yeah, but you know what? I mean, one of the frustrating things is that people come in that haven't been taking care of themselves and expect us to make everything perfect, and we can't do that. You know, America. We can give you a second chance, but people have to take responsibility for their own health and their own well-being.
That is exactly right, and that's probably one of the reasons we're doing this educational show. Hopefully people will start understanding it's in their hands more than it is ours.
Right.
You, I know that you started doing something called the maze procedure for, arrhythmias like atrial fibrillation.
Right. Atrial fibrillation is a big problem in people. It can cause strokes, it can cause a decrease in your exercise tolerance and so forth. We've been doing a lot of treatment of that, especially in conjunction with the valve surgery, where you try and reroute the short circuiting that occurs in the heart. Most of what we're doing is like half surgical and half creating these pathways with radio frequency is what we use a lot with special instruments.
And your success rate is very good with it.
Well, the success rate is good in people that haven't had it for a long time. It's not as good for people who have had it for 10 years. But yeah, if we can correct that, get them off the Coumadin, it's a very good thing.
So Craig, I see that you're doing many more difficult cases than you probably did throughout your career. And I know we transfer many cases throughout the state, throughout the different Barnabas systems. Are you seeing more? Are you seeing this? Are the cases getting tougher and tougher?
I laugh every morning I drive to work because I drive past billboards of hospitals saying that we're #1 or we're in the top 50 or whatever. Hospitals with banners saying we're in the top 5%. And I come to work and I'm doing patients that have been transferred from those hospitals to our hospital to have definitive care.
Well, that says a lot. Well, Craig, this is very informative, and thank you for your time today. And hopefully we see each other soon.
Thank you.
Sometimes a common ailment only needs a simple solution, or sometimes it can be an indicator of a greater issue. Either way, any concern should not be ignored. Here at the Medical Health Center, we welcome you to just walk in at any time. As we get older, the bones naturally lose calcium and vitamin D, so they become weaker. We do a bone density to assess that density to see if they need to be on medications or be supplemented with at least extra vitamin D and calcium. You have to take charge of your own life and make these decisions. It's easy enough to just walk in and have all these testing done, and then at least you have peace of mind. Why would you want to wait in the emergency room when you can come to our office and have all these things done? And then if you need to go to the hospital, we can always refer you to the hospital. But come here first and get it all done.
I'd like to talk to you about preventative care and self-reliance. In other words, taking care of your own health care. Sure, we live in a time when medical innovations can offer you pills, stents, surgery, but what's it going to be? Stents and surgery, or diet and exercise? We hope you can develop healthy choices for a long, healthy lifestyle. Since it's in season out of strawberries, raspberries, and blackberries, there's lots of snacks you can make up that are quite good. For instance, this is a mixture of nuts. We have some pecan nuts, we have some all different type of nuts that you can buy in any store. And I just like to mix the nuts together, and a quick snack, whether you're in an office or at home, it's satisfying and the calories are very low. Now I just put in these bowls a mixture of some strawberries, raspberries, and blackberries, and I happen to like sliced almonds, and I love them. You can put them in salads, but I love to put just a little bit around with my fruits and just have that as a snack. Another way that we have another mixture of fruits, again, just a little dab of whipped cream on top of the fruits is another way of serving it. And lastly, you know, we can put whatever fruit you like, and we have the same strawberries, raspberries, and blackberries. We're going to add some almond milk. And I've added like 1 or 2 ice cubes. And you can have a nice smoothie with a little ice. And the last thing, I love these strawberries. You can cut these strawberries, just put a little lemon on them, and just put a little sweet and low over them. Put them in the refrigerator, and they're good to go, and they last for days, and they're delicious. So here's some quick, easy snacks that are healthy for you, and will help you live a better life. Ready? How's that? Remember, choices take only a moment to make, but can last a lifetime. So make sure yours are healthy ones for you and your loved ones. I'm Dr. Joseph Clemente, keeping the community connected to good health. See you next time. We will always be accessible, whether it's in Hazlitt, Middletown, Red Bank, Tinton Falls, or any of our other offices. Since this is an educational show, and it definitely helps with patient care when they're well informed, if there are any particular issues that you'd like us to address, please contact us and maybe we'll use your suggestions.